If you're at the opening ceremony, you heard Guy Marks mention that in high-burden settings, most TB is from recent transmission. So in many ways, TB control is about controlling transmission. And as Guy mentioned, through a variety of means, including finding all the cases and treating them. If you're interested in airborne infection, you're going to want to get this book eventually when it's published. This is a pre-publication draft of a book called Airborne by the New York Times science writer Carl Zimmer, and it's a very detailed history of our knowledge of airborne infection from very early days and then through COVID, and it deals a lot with some of the history that I'll just mention very briefly. We also have a review that Peter Donald and I and a number of other people did on the European history. There's a lot of literature in German and French that most of us aren't aware of, and Peter was able to dig that out, and we have this droplets, dust, and guinea pigs, a historical review of tuberculosis research. It isn't all that long ago that people weren't sure how TB was transmitted, and when you had whole families like the Bronte family in England, where members of the family were dying of TB, you could understand that people thought it was hereditary. But of course, in 1882, Koch discovered the tubercle bacillus, and it became clear that this was a bacterial-caused infection, but yet it remained a little bit of a mystery how it got from one person to a person. And even as recently as 1930, there were signs in England like this: don't spit because it might transmit TB, and also warnings about sweeping because you might stir up dust that might contain tuberculosis. So the exact mechanism wasn't clear, and we should be very familiar with that because we just went through a pandemic where the exact mechanism of transmission was unclear for quite some time and argued about. One of the important innovations was a man by the name of William Wells, who's pictured there in the corner, who happened to be at Harvard. Actually, a remarkable guy, only had a bachelor's degree in engineering, but he was a true genius, and he came up with a lot of very innovative ideas, including one to develop an air sampler to actually pull bacteria out of the air. And you see a picture on the right-hand side of what these devices look like, and a little bit cumbersome, but it was essentially a vacuum cleaner, and that would spin around glass tubes that would pull bacteria out of the air, and that was used to prove that infection could be spread by bacteria in the air. I didn't even know these were manufactured, but I found out that one existed at the University of Leeds, and it's being shipped to Harvard for the museum there because it has an important place in the history of airborne infection. Likewise, Richard Riley, who was a medical student at the time with Wells, shown in holding his picture, they investigated a textile mill where workers were getting sick, not with tuberculosis, but with other infections, and showed that you could pull bacteria out of the air that might have been causing that illness. Now, one of the reasons why TB in particular is sort of a prototype airborne infection is that it needs to get to the very depth of the lung, to the alveolus, to cause infection, and only the very smallest particles can make its way through the bronchial tree and make it all the way to the alveolus, and usually in the 1 to 2 micron range. And so I think Wells was guilty of sort of classifying airborne infections as being one of two categories, either airborne, very small particles, or droplet-borne. And recently, with the COVID pandemic, the aerobiologists have argued, it's a spectrum. It goes from very tiny particles to larger particles that we call droplets, but there's no clear cutoff. Very large particles can be propelled through the air with ventilation, for example, or moving air, and travel far distances. And I recently was on a panel at the WHO over the terminology and there was huge contention, because as soon as you say airborne, that brings to bear certain responses in terms of using respirators instead of masks, for example, which we'll be talking about in this course. And there's a lot of heated debate over when you use that term airborne and what it means. So, but in terms of tuberculosis, clearly airborne. Some other things, because the receptors are higher up in the respiratory tract, can be transmitted by larger particles and even into the respiratory mucosa or the eye and that kind of thing. So influenza can be airborne infection, and it also can probably be spread by droplets. Not so with tuberculosis, it's really all airborne. Now, the other way you can show that infection is airborne is if you disinfect the air and you stop the transmission. And that was done in the 1930s and 40s, again by Wells in school outside of Philadelphia, where they put up germicidal UV and showed that they could suppress a lot of the transmission. You can see in the upper panels that there are many fewer cases of measles in the rooms with germicidal UV than in ones without it, demonstrating that measles well, we know that as the other prototype, probably the most infectious airborne of all the viruses. Then the definitive study was on this subject was done by an idea of Wells and carried out by Riley in Baltimore, as you know, where patients infected guinea pigs some distance from the patients, and that proved that only air that was going through the ductwork was making it to the guinea pigs. So I could spend the whole 20 minutes or 15 minutes that's left on this slide, and I'm not going to do that. But it's a schematic that really shows the infectious source, the host, the people who are vulnerable, and the organisms that make it in the air, and sort of some of the factors that are involved. We're going to talk about cough and whether that is critical or not. We always think of in tuberculosis with sputum smear and lung cavities as being important. We had a whole pandemic of recommending surgical masks to cut down on transmission. And then in the environment, ventilation, we'll be talking about that, and germicidal UV. And drug treatment and drug resistance are part of this whole story. I mean, treatment stops transmission incredibly quickly, but not if there's drug resistance. And then on the other side, with the host, we can talk about innate immunity, and then the immunity you can get from previous infection, which reduces transmission. We talk about isolation. And one of the things we realized in the course of studies that treatment is so effective in stopping transmission that most transmission in hospitals must be from people who aren't on treatment. Now, the irony is that a lot of infection control and prevention tends to focus on patients in hospitals who are actually on treatment, and whether, how long they stay in isolation rooms and what those conditions should be. But finding cases who are not yet recognized is critically important, and getting them on proper treatment. I was terribly impressed with the data that Guy Mark showed of what's happening in Vietnam, or happened over a period of months, when you really did screen for all cases of TB and get them on treatment. So what I'm going to focus on for the rest of this is a very controversial topic in our field right now, is that how important are symptoms and how much transmission is occurring from asymptomatic cases. And it's kind of in vogue right now to say that, oh, we've had it wrong all these years, that we're focusing on cough and symptoms, and that really it's the asymptomatic patients that are doing most of the transmission. And that may be true, and it may not be true entirely. Or at least I think we'll come to realize that it isn't one or the other. But if you look at this diagram, we sort of have preclinical transmission, and that's what's being talked about, what happens before we recognize patients with symptoms. Household and community, and some of that is in the household. So it's pre-symptomatic or pre-transmission, when people get infected and are not yet infectious, then before we recognize them and get them on treatment in the household and community, and then finally how much transmission occurs once people are on effective treatment. Now, there's a study here which is a little hard to see, the Rotterdam household study, which showed that in a very careful epidemiologic study in Holland, that only 28% of sputum-positive patients infected any household contacts. So we know that TB isn't measles, that it's a much lower level of transmission, and these are all pulmonary smear-positive cases, but not all of them were infectious for their household contacts. Now, they were all breathing, I suspect, so it isn't as if the transmission automatically occurs because one has tuberculosis. So this is it's an editorial by Christina Yoon that is time to move on beyond symptoms. And I think we all realize, and we learned this, we tried to implement in Peru, we tried to find cases going to the hospital and ask people about symptoms, and we're screening those patients for tuberculosis, and really the yield was very low of patients coming to the hospital, thinking that if it isn't the patients who are known in the hospital with TB, it must be the people we don't know about, and can we find those? And symptoms are not very reliable in terms of finding all the cases, for sure. And it's argued, based on prevalence studies, that about half the patients ultimately who have TB don't have symptoms. And it is also true that DOTS, which was very much based on symptoms, really has never been shown to have an epidemiologic decrease in tuberculosis anywhere it's been applied. So what has evolved is that DOTS isn't enough, that we need active case finding to find other cases. The question is, are those cases symptomatic and not found yet? Are they coughing, or are they patients who are in the community who are not coughing and remains transmitting? And so, again, there's one of the papers shown here from David Dowdy and Kendall suggested that basically subclinical tuberculosis may be terribly important in terms of transmission. I think it's true that we have sort of dismissed subclinical tuberculosis, that if people don't have cough, we would say, oh, they're not infectious. And they may very well be infectious. The question is, where do we focus our attention most? There's another paper focusing on asymptomatic patients, 414 index cases, and in 3 prevalence studies in Bangladesh, Vietnam, and the Philippines. And it suggested that because of the length of time that people are asymptomatic, they might be twice as infectious as during the symptomatic period. And again, I think there's a problem with this because asymptomatic patients are really hard to study because they don't have symptoms. So I think we all know that if you ask people about symptoms, they may not be terribly aware of them, they may deny them because they're stigmatizing. And so are symptoms reliable? So when people say, oh, 50% of patients are asymptomatic, are they really asymptomatic, or they just deny symptoms? So that's one of the problems with this. And then there's the issue of super spreaders. Not only in tuberculosis, but in a number of infectious diseases, it's been argued that a very small percentage of the patients actually account for a large percentage of the transmission. And this is completely contradictory to what's being said about asymptomatic TB, where a large number of asymptomatic patients are doing most of the transmission. They can't both be true, but this is a paper from suggesting that of 15,000 contacts of over 4,000 pulmonary and some extrapulmonary cases, and it suggested that it was the symptomatic, clinically detected patients that accounted for the vast majority of transmission. So I think there's some contradictions going on. And the final Well, there's more data. This is actually from Robin Wood's group in Cape Town, where they have people in a chamber and they measure particles, and the particles that are actually test positive as tuberculosis by molecular detection. And they argued that although cough, if you ask the patient to cough, they generate more particles than if you don't ask them if they're quietly breathing. Since breathing occupies much more of their time a day than coughing does, that quiet breathing must account for much of the transmission. And I think there's some major problems with this paper. And first of all, they're particles, that's not transmission. And the patients were asked to cough. That's very different than patients who can't stop coughing because they have a cavity that's eroding into an airway, and have absolutely uncontrollable coughing with tens of millions of organisms being released into the airway. So in this paper, there's no mention of x-rays, there's no mention of cavities, there's no mention of HIV status. And as we know in South Africa, HIV is quite prevalent and in TB patients, 60% perhaps. And so it's not the best place to come to big conclusions about how symptomatic or asymptomatic TB is transmitting, because it's not TB, it doesn't represent TB everywhere in the world. Then there's the biology itself. This organism and the host have evolved very elaborate mechanisms together. We have defenses against tuberculosis, but we've also, those defenses are its undoing, because all of the damage we see in the lung is a result of an immune response to the organism. And you know, the organism has very cleverly induced what is called liquefaction necrosis, which leads to these cavities, which leads to erosions into the airway, which makes patients incredibly efficient disseminators, the super spreaders that we just talked about. So if quiet breathing was all that was necessary to transmit TB, why is this all necessary to have cavities and induce coughing and transmission? So I think the jury is still out, that we have underestimated quiet breathing as a source of transmission, but that indeed super spreaders need to be worried about, and coughing is an important factor in those patients. So my last slide is that what we know is that TB is airborne, and a number of other infections, of course, are airborne, COVID among them. And we also know that effective treatment rapidly stops transmission. In the United States, we've just reduced our quarantine period, a recommendation, from 2 weeks, which was traditional, to 5 days, thinking that there is evidence that patients respond that quickly. And undiagnosed and untreated cases in healthcare facilities are an important source of transmission, and we need to find them. And we had an acronym for that: find cases, actively separate and treat effectively to stop transmission. The unknowns, I think right now, of importance are how important cough is in transmission, how much community spread is by asymptomatic persons, and what kind of population screening, such as Guy Marks referred to in Vietnam by mass x-rays, can be reasonably brought to bear to find those unsuspected cases and get them treated, if indeed that is the way to TB elimination. And so with that, I'll stop.